I'll admit it. I was an early advocate of video laryngoscopy. And I say that as someone who grew up as a paramedic and as an emergency physician using direct laryngoscopy. In 1988, when I graduated from paramedic school, video laryngoscopy wasn't even close to an option. We didn't even call direct laryngoscopy. It was just intubation and laryngoscopy. When I started residency in 2005, we had a glide scope, but to be honest, nobody knew how to use it. And I don't mean that they didn't know how to push the buttons and turn it on. I mean, nobody understood the technical differences in laryngoscopy, or more importantly, in tube delivery. If anyone did understand the difference between standard and hyperangulated blade geometry, they certainly didn't bother to teach it to me. One of my faculty, Dr. Dorian Dragala, figured out I was pretty comfortable with DL, so he forced me out of my comfort zone and made me use that glide scope. And I hated it immediately. I had what I now recognize was the classic experience when someone is experienced in DL and they're handed a hyperangulated blade. I had an almost unbelievable view of the larynx, but I couldn't for the life of me get that tube through the cords. Now, as a result, I sucked at intubation again. I felt like a brand new paramedic student all over again, and I hated it. Now, while knocking my ego down a few notches was probably a pretty good idea, it wasn't exactly helping me learn to use that glide scope. As soon as I got out of residency, I went straight back to my comfort zone and I used Mac blades exclusively. Life was good. I was happy. My success rates were back up, and that shiny new glide scope, it sat unused in the corner of the recess room where it belonged. That is until the glide scope rep came to the department all bright and bubbly and asked me how I liked his toy. I'm not exactly known for beating around the bush, so I told him I thought it sucked. He'd give me this great view, but it made it almost impossible to pass the tube. Now, fortunately for me, this rep had clearly heard this before, and he understood the different blade geometry required a different technique. And he also seemed to understand that some pig-headed attendings just need to be hit upside the head with a 2x4 in order to get their attention. So he straight up told me I didn't know what I was doing, and that's why I sucked at it. As it turns out, he was right. He showed me how to use a rigid stylet that had the same shape as the blade and how to maneuver that stylet and pass the tube. And I've been a convert ever since then. So I wrote a paper describing the dramatic improvement in intubation success we experienced at Williamson County EMS when we moved from DL to the King Vision channeled VL. As most new converts were to something, I became a bit of a zealot when it came to preaching the benefits of VL. I was kind of like a vegan CrossFitter. I made damn sure you knew that VL was the greatest thing since sliced bread. I jumped into the VL-DL debate with gusto on Twitter and at conferences and basically every inappropriate place you can think of. I might have even tried to convince someone in a public restroom once. Fortunately, I didn't get arrested for being a VL groomer. But anyway, I eventually realized three things. Number one, zealots rarely change anybody's opinions, but frequently they annoy the hell out of them. Two, literature at that time actually did not support that VL had a higher first pass success rate than DL. And three, if VL had the advantage I thought it did, time would solve this debate for me. I just needed to sit down, shut up, and let it happen. Eventually, enough people would learn how to use VL, they'd get sufficient experience with it, that VL rates really would catch up, and then they would demonstrate the advantage that I knew it had. It's just a matter of time. Well, I think that time has come. Stick around because I can't wait to tell you about the device trial.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, where we shine the bright light of science on the darkness of current EMS clinical practice. We're talking VL versus DL again after I took some time away from this argument. It was honestly getting a little old, and the literature was being rather rude and not saying what I wanted to say. Damn literature. The paper I did at Williamson County with John Gonzalez, Sarah Francis McClure, and Danny Johns showed that we increased first pass success from an absolutely abysmal 44% with DL up to better 77% with VL. Now, looking back, I'm actually kind of embarrassed at our 77% first pass success rate because by the time I left Williamson County, the first pass success rate was up in the high 80s, low 90s. Now, I still love that thing, the King Vision channeled blade. I love it. I love everything about it except for the fact that it doesn't friggin' record. Okay, that's just a little anger venting there. But it turns out when I looked at other literature, I was shocked that it didn't show the same thing. I was absolutely horrified when I read Ducharme's paper about an EMS-based crossover study that found a non-significant trend toward actually lower first pass success rate with the King Vision. That was just beyond something I could believe. 67% versus 63%. Now, I'll admit I was absolutely convinced those results were because they didn't know how to use the device. But the results are the results, and I had to admit that it was reasonable science. My thoughts on why people are unsuccessful with the King Vision, very much like most VL devices, is that they go in too deep with the blade. I went as far as showing people how to hold the blade in what I called the correct position. I still maintain that simple action, how you hold the blade, improves success, but I might have been just a little bit dogmatic about it. Then in 2017, Savino published a systematic review and meta-analysis of pre-hospital studies comparing VL to DL, and he stratified those results by physician and non-physician operators. They found worse first-pass success with VL than DL in physician hands, but better first-pass with VL in non-physician hands. Now, presumably, this was a marker of the influence of education and experience of the operators. Now, earlier this year, Dr. Pourmand and colleagues published another systematic review and meta-analysis. This one included several additional papers published since Savino's paper. Now, this showed a significant benefit in terms of first-pass success, overall success, and the number of intubation attempts with VL. It was just a matter of time. In 2020, Brown and his colleagues used the NEAR registry of emergency department intubations to compare first pass between VL and what they called augmented DL. Now, augmented DL included all the usual techniques and adjuncts used to improve intubation success, things like a bougie or ramped position, things like that. They also showed better first pass success with video laryngoscopy than any type of DL, regardless of how it was augmented. Finally, in 2022, just last year, Hansel published a Cochrane systematic review and meta-analysis that compared both standard and hyperangulated VL blades versus DL and found higher success with either of the video blade geometry, including channel blades. Love to hear about the channel blades. Now, this is the most up-to-date systematic review I can find, and it shows there is a benefit to VL in emergency department patients that's similar to what Pourmand found with pre-hospital patients. This progression of improved success with VL over time, that has further convinced me that my suspicion was correct, that VL would announce its benefits just with time as more people gained VL experience and learned the distinct techniques that are required. It seems to me that this question, although I think we're getting pretty conclusive evidence, what it really needed was a cherry on top. You know, maybe a nice multi-center randomized controlled trial of first pass success with VL or DL, just as an example. Well, fortunately, that's exactly what Dr. Prekker and his colleagues gave us with the device trial. So let's get to it. So the direct versus video laryngoscope or device trial was a multi-center randomized controlled trial comparing direct to video laryngoscopy in hospitalized adults in the ED or ICUs of 17 academic medical centers in the United States. It was what the authors called a pragmatic trial. That means they didn't protocolize anything in the trial other than the type of laryngoscope used on the initial attempt. Now, the downside to pragmatic trials is there are more uncontrolled variables in the trial that could potentially bias the results. The upside, however, is that they typically better reflect usual practice in the community, and as such, they're better able to generalize the results to other similar populations and practices. And while it introduces the potential for bias from uncontrolled variables, the randomization process really ought to equally distribute those uncontrolled variables between the groups to mitigate that potential. The other not entirely inconsequential benefit of pragmatic trials is that they're easier and they're cheaper, which means they get done and we get to benefit from them. It's kind of hard to learn from a trial that doesn't get completed. Now, patients were randomized using a computerized process stratifying the assignment by trial site, and it was done in a way that attempts to equalize the number of patients in both groups are enrolled at each training site. Assignment was placed into envelopes and distributed to all of the sites. When a physician determined the patient was eligible and would be enrolled in the study, they just got the next envelope in sequence, opened it up to see what type of laryngoscope blade they would use on the first attempt. Now, with that discussion of methods out of the way, let's hit the PICO question. So the population was adults 18 or over who required oral tracheal intubation in either the ED or the ICU. The intervention and control here were either video or direct laryngoscopy. Exclusion criteria were the usual P suspects. Pregnancy, pediatric patients, prisoners. I do love me some good alliteration. Now, they also excluded patients who, in the opinion of the treating clinician, had either a clear indication or contraindication for VL or DL, or for whom they felt there was insufficient time available to go through the enrollment process safely. This exclusion was put in place, I suspect, to satisfy the IRB. I'm going to talk more about that in just a second. Now, the only thing randomized was the use of VL or DL. The intubating clinician was free to choose the device or blade geometry within the arm they were assigned to. There's no additional training provided for any device, and that is part of the pragmatic nature of the trial. The primary outcome here was first pass success as determined by an independent observer. Secondary outcomes included first pass success without serious adverse events, including hypoxia or hypotension, and first pass success on first blade insertion into the mouth. Now, if that sounds like two different definitions for first pass success, good for you. You're right. It was. You should now go back and listen to episode 74 if you missed it, because we discuss a paper by the same author group describing the rationale and impact of using a more stringent definition. The bottom line for those who listened to that episode is they used the more stringent definition for first pass. And as a result, they would expect the first pass success in this study to be lower than in prior studies. So let's talk about IRB approval, shall we? If this study were being conducted in the field, I suspect it would require ethic or exception from informed consent. This can be a rather laborious process of community notification, and it usually requires patients or family to consent to inclusion of the patient's collected data after the fact, because the assumption is the patient was in extremis and unable to give informed consent, but informed consent was still needed as soon as possible. In this case, their IRB said consent was not needed at all for the following reasons, and I think these are important. Number one, the patient is in extremis and rapidly needs intervention, making informed consent impractical. Well, that is certainly true in the field. Two, the attending physician has already determined the patient needs to undergo orotracheal intubation, and common practice is to use either DL or VL. The physician must also not think any characteristics of the patient would require or prevent either DL or VL from being a reasonable option, again, applicable in the field. So both treatment options have to be deemed acceptable by common practice, both have to be approved, and both have to be regularly used in the ED or ICU. The only risk to the patient then is that of data breach of study material, and that is typically deemed to be no more than minimal risk. To be clear, I am not opposed in any way to this rationale. Instead, I'm jealous of it. I think it should be the same concept applied to EMS research. Maybe if that were done, we might get some more research done. So those are the methods. This was really a pretty straightforward study. To summarize, they enrolled patients needing intubation in 17 different emergency departments or ICU to have their first attempt with either VL or DL. Everything else was left to clinician judgment. With that in mind, let's get to those juicy results. Based on their sample size calculation, they wanted to enroll 2,000 patients. They were obviously going to evenly divide those between VL and DL, and as is the norm, they were going to do an interim safety analysis after they got the first 1,000 patients enrolled. Now, before they began enrolling patients, the safety committee went ahead and defined criteria under which they would stop the enrollment. And the only reason you would stop the enrollment is that you have reached a point where additional data collection is not going to change the results. You either see clear benefit to one or the other, or you determine that no matter how many additional patients you're going to enroll, you still won't get to the point where you can see significant results. So, predefined criteria. And that brings us to the interim analysis. At that analysis, the independent safety board stopped the trial because there was evidence of efficacy. In other words, they found that the two arms of the trial were no longer at equipoise, and that means they both had a chance of being shown to be superior. Since this was no longer the case, even if they continue to enroll patients, they wouldn't be able to get different results. So they stopped the trial. Now, the headline here is that VL had higher first pass than did DL. Using the more stringent definition of first pass success, and that definition is the intubation was successfully accomplished with one blade insertion and one ET tube or bougie passage. Using that definition, they found an 85% success with VL compared to 71% with DL. That was an absolute difference of 14% with a 95% confidence interval ranging anywhere from 10 to 19%. Now, I've seen lots of people on Twitter arguing because these first pass success rates are low in both groups, the results couldn't possibly be generalized, say, to them. And everybody should just train more on whatever device they're using, and we don't have to worry anymore about this study showing maybe that DL isn't as good as VL. I don't like the results, therefore I'm going to find a problem with them. And in this case, the problem is low success rates. Well, I think it's really important to remember this study is using a more stringent definition of first pass than most of us use. Now, I don't mean to harp on this. All right, so maybe I actually do mean to harp on this. But at least from the discussion I'm seeing on Twitter, people are missing it and it needs to be harped on. So harp I'm going to do. Now, in order to be considered a first pass success in this paper, the tube had to be placed through the cords with one attempt at laryngoscopy and one attempt at tube or bougie passage. Now, this same author group wrote a prior paper about this, and they used two different definitions, the more stringent definition and the typical definition, which is you pass the tube with one attempt at laryngoscopy and any number of attempts at tube passage. They showed that the more stringent definition resulted in a first pass success rate about 5% below the usual definition. Now, if that 5% is applied here, well, let's see, 85 plus 5, the first pass success rate would be 90% with VL and 76% with DL. Now, fortunately, to help evaluate the impact this new definition made, they also reported first pass success using the old definition and found, wait for it, 90% first pass with VL and 77 with DL. That's pretty damn close to what they predicted. Now, using this definition, we still see an absolute difference of 13% favoring VL, and that was significant. Now, using the more stringent definition, they also calculated first pass without severe adverse events, primarily being hypoxia, hypotension, or cardiac arrest. They saw that in 69% with VL and 59% with DL. That difference, 10%, and the confidence interval is from 5 to 15, meaning it is significant. Now, this was listed as a secondary outcome, but I actually think it's probably more clinically relevant to patients than first pass by itself. Now, they also measured duration of the intubation attempt, and with VL, they saw that it was a median of 38 seconds compared to 46 seconds with DL. That's 8 seconds faster, and that, again, was significant. There are some other interesting findings in their secondary analysis that are worth digging into, but first I want to get a better idea of the population that was included in this study. Now, overall, the groups were well balanced, as you would expect from a randomized controlled trial. In total, they enrolled 1,417 patients. 70% of those were intubated in the emergency department and 30% in the ICU. The majority in both groups were intubated with a diagnosis of sepsis or trauma. The two top indications for intubation were altered mental status, that was 45% across both groups, and respiratory failure in 30% across both groups. Now, 10% of the patients in the VL group were anticipated to have a difficult airway compared to 9% in the DL group, and that's basically the same number. The authors include a nice forest plot. Oh, how I love me a forest plot. That forest plot was in figure 2, and that gives the results of a lot of different subgroup analyses that they did. They looked at first pass rates by location. It was better with VL. High versus low BMI, better with VL. Trauma versus no trauma, better with VL. Anticipated difficult airway versus not, still better with VL. The only place where the confidence interval overlaps 0, meaning the point of no significance, between VL and DL is for those operators with more than 100 prior intubations and with operators with less than 25% of their prior intubations being done with VL. Now, in both of these cases, the point estimate still favored VL, but because there weren't many of those operators, the confidence interval was a little wider and it crossed 0. No difference. So there's been a lot of discussion around who was doing the intubations, and I think this discussion is really important and it's really fair. This was a multi-center trial at an academic institutions, so it should be no surprise that most of the patients intubated were done by either a resident or an ICU fellow. In fact, 70% of all patients were intubated by either EM residents or critical care fellows in 25% of the case. Now, 2%, just 2% were intubated by an attending, and just under 3% were intubated by some other specialty, including paramedicine, I like to see. We're going to dig into this thing about experience more in a little bit, because I really do think that is the really important part of this trial. Now, overall, these patients didn't seem to be that hypoxic. The median saturation at the time of induction, 100%. That was done in both groups. Less than 15% were on BiPAP in the hour prior to induction, and it didn't seem like they were very hypoxic before they started pre-ox. The median nadir saturation in both groups was 95%. The vast majority, meaning more than 80%, were inducted using etomidate, 20 milligrams, and about 10% were inducted with ketamine. More than 70% were paralyzed with rock, with the remainder getting either SUCS, which was probably another 25%, or no paralytic, presumably for those patients in cardiac arrest. Now, of the VL group, 86% were intubated using a standard geometry blade, the other 14 with a hyperangulated blade, none of which, unfortunately, were channeled. And I say unfortunately because I'm a channeled fan. 51% of patients in both arms used some form of stylet, and 45% across both arms used a bougie, and the proportion using stylets and bougies was no different in either arm. So this was an intention to treat analysis, and that means that each patient was analyzed in the arm that they were assigned to, regardless of whether they received that assigned therapy. Now, that's an appropriate response. That's what we expect to see in RCTs. In this case, there were 707 patients enrolled and assigned to the VL group, and all of them got intubated with VL. Now, if you're keeping up with the numbers, you'll see 2 patients were excluded from analysis because they were later found to be prisoners. Of the 713 patients assigned to DL, however, 8 of them were actually intubated with VL instead of the assigned DL, and the reason for this is interesting. It's described in the supplemental materials, specifically table S8. We see 63% assigned to DL got VL because the patient deteriorated and the clinician now felt VL was clearly indicated. The remaining were because they anticipated a difficult airway, and that airway was going to require VL. And one of these patients included a spinal cord injury. And I think the common thought there is that you get less movement using VL. As a result, they felt the patient needed VL and they violated the protocol. Now, the most common reason for failed attempts with VL, and this was 17%, were because the operator couldn't adequately expose the vocal cords. The most common reason with VL, and this was 6%, was an inability to pass the tube through the cords. And these results match my experience and most of the things that I've heard that are challenging about intubation. So for DL, the hard part is exposing the cords, directly manipulating things out of the way so you can get a direct line of sight view of the cords. With VL, particularly these hyperangulated blades, you get an amazing view of the cords almost no matter what you do. But because it is indirect, you're looking around the corner of the soft tissue, getting the tube to go where you want it to is now a challenge. So it turns out that these results reflect the common understanding of these problems. Speaking of failure, one reason many advocates of DL say they like DL instead of VL is because of device failure. Well, what do you do if the device fails? Those video laryngoscopes, newfangled technology, they're going to fail left and right. DL is far more reliable, they say. Well, they looked at that in this study, and it turns out there were fewer VL device failures than there were with DL. There were twice as many DL failures, in fact. Now, granted, these are small numbers. There were 2 with VL and 4 with DL, but still, I'm really not worried about VL failing, at least any more so than DL. And if it does, we do the same thing we would do if DL failed. We move to a backup device. Supraglottics are very reliable these days. Now, another big criticism of video laryngoscopy is that apparently one cannot intubate a patient with a bloody airway. Now, I got to say, this is kind of surprising to me since I've certainly done it. My paramedic colleagues have certainly done it, but maybe our experience is different. I've seen claims that there must not have been any bloody airways in this trial since VL was found to be superior. And if there are bloody airways, VL clearly fails. Therefore, these results would never have been seen if there were bloody airways. Well, going back to the supplemental materials, table S11, that tells us 17% of patients in the VL arm had bloody airways. 19% of the DL group had bloody airways. Now, my take on this is that everybody would be well served to learn and practice Dr. Jim DeCanto's salad maneuvers to allow intubation of soiled airways regardless of the device they're using. Now, about that experience issue, how experience confounds the association between device type and success is absolutely fascinating, and I think it is the key to understanding what to do with the results of this study. I think the evidence at this point is pretty clear that overall VL is associated with higher first pass success and fewer failed airways. That's based on both this paper and the systematic reviews we talked about earlier. The association between VL and fewer adverse events, however, is less strong. We do see it in some papers, but not all, which brings us to this paper. Did we see any difference in adverse events? And the answer is no, we didn't. That's important to know. Now, the path we took to get to these results, meaning historically, is also important. Initial studies did not show improved outcomes with VL. Those of us who learned how to succeed with VL were absolutely confident that once people just learned how different devices need different techniques and became comfortable with those techniques, we would see success rates improve with VL. And that's what we've seen in the literature. VL is different and we need to train differently with it. And that has taken some time. So we might expect those clinicians with extensive experience with DL and little experience with VL to still be more successful with DL, and vice versa. Now, there is a really strong signal in this paper that is exactly what we're seeing. The authors recorded lots of detail about the operators who are performing intubation, including their prior experience and how much of that experience was with VL. The median number of prior intubations, remember these were largely residents and fellows, was 50 in both groups. Between both groups, 6% of operators had less than 25% of their prior intubations done with VL. This group clearly was less experienced with VL. There was another 55% or 59%, that used VL on somewhere between 25 and 75% of their prior intubations. And that leaves 36% of operators who had used VL on more than 75% of their previous intubations. This group made up a little bit over a third of all of the operators, and these were the most experienced with VL intubation. Now, they include some nice data viz in the supplemental analysis, and because I'm a nerd for data visualization, I got to talk about it. And just in case there's any doubt, I'm the kind of nerd that really likes to read the supplemental materials. I kind of really nerded out on figure S2. It's a dot plot that shows the intersection between the total intubation experience on the x-axis and the proportion of that experience that was done with VL on the y-axis, and the dots were different colors based on specialty. Now, just looking at this plot, it's pretty obvious that the majority of operators in this trial had less than 100 intubations total experience, and most of those were with with VL. Now, all of the data points in this plot are clustered in the upper left. That means less intubations overall, but more of them were with VL. And the area down in the bottom right, that is, you had lots of intubation experience, very little of which was with VL. That area is a wasteland. It is barren. Nobody lives there. This describes a group of newer intubators with lots of VL experience. And it also describes the group that is not included in this study, and that is those with a great deal of experience, particularly with DL. Now, there was also an association between the experience and success. Now, I really love the heat map that they show in figure S7. It again plots each operator on a graph with the number of previous intubations on the x-axis and the percent of those intubations done with VL on the y. But the dot showing the intersection there is colored to show the difference between VL and DL success. And what you see is a clear association between experience and success. Not surprising. The only part of the plot that favors DL is that bottom right part at the intersection between lots of experience with very little of that being with VL. Now, although VL had higher success rates than DL throughout the range of experience, there's another plot that helps define this relationship between experience and success with VL. Figure S4, did I mention all the good stuff is in the supplements? Figure S4 shows the success rates of VL and DL as a function of the number of prior intubations done by that operator. At all points, VL is higher, but the confidence interval for VL and DL success begins to merge above 100 intubations. That means the difference is no longer statistically significant, and this suggests that for those with fewer than 100 intubations, VL is clearly associated with higher success. Well, that's pretty much it for the trial itself. Let's wrap up this already long podcast with what I think the key takeaways are. First, I think this was a well-done trial and provides strong evidence for the superiority of VL in terms of first-pass success over DL in this population and in this group of operators. I also am, again, a fan of their new definition of first-pass success, and that is one blade insertion and one attempt at tube or bougie passage. I'm working to sort out how to systematically measure -1A in my system, and when we get that sorted, we're definitely going to be using this definition. Now, just a note to, King Vision. In order to measure this, you have got to have video recording. It's the only way you can measure it. Modern charts don't show the number of attempts at ET2 passage, just the number of attempts at laryngoscopy. You got to have the video, so get with the program, guys. Get us recording. Now, I think these results are generalizable, but with some limitations. First, this paper excluded children. Therefore, it cannot possibly inform pediatric airway management. You've got to look elsewhere for that. Next, the operators here were primarily, almost exclusively, as a matter of fact, EM and critical care physicians, and almost exclusively, more than 90% trainees. They did not include anesthesiologists in the OR, There were some, like less than 2% of anesthesiologists doing intubations either in the ICU or the ER, but none in the OR, and that means these results should not be generalized to that environment. Now, they also didn't include pre-hospital intubations. But even though they didn't, I have no reason to think these results should not be extrapolated to the EMS environment. And I say that because there's clear association in this paper between overall experience and VL experience in particular and success. Less experienced operators clearly did better with VL than DL, and this is not the first paper to show that. Now, while there are exceptions to every rule, don't at me, Twitterati. I know there's one paramedic out there who's amazing. You truly are. I'm not talking about you. In general, paramedics have less experience in intubation than emergency physicians, including EM residents. Now, the EM literature, including meta-analyses, shows the same thing. We moved in my system to VL because we're better at it, just like the literature shows. I think it is also important to point out that this literature, this paper, does not apply much to those attending physicians who are heavily experienced and successful with DL. And most anesthesiologists in practice today are almost certainly in this group. I'd say they should continue doing whatever they've been doing. For them, there's nothing to see here. Move along. Do what you've always been doing. You be you. You're good at it. Don't read this paper. It does, however, probably influence how they might want to think about training the next generation of anesthesiologists. Now, I really enjoyed reading this paper. Like many of y'all, I enjoy airway management. I enjoy reading papers about airway management. And this is a well-written paper, and I strongly encourage anyone with an interest to read this paper. Now, if you've been screaming at me throughout this episode about how these results do not apply to you because reasons, I definitely think you should read this paper. Of course, if you've been screaming at me, you're probably not still listening. But still, read the paper. So, with these results, I think it's really kind of pointless to keep studying this issue. I think we have the answer, at least for adults intubated outside the OR and by people with less than 100 intubations. And that's getting to be more and more of our population. I think future work would be much more productive, if you tried to identify the best techniques to use with different VL blade geometry. That, I think, is a concept that is still inadequately understood. I would love to hear your thoughts on this paper, and I'm sure some of you are going to tell me how completely wrong I am, and I want to hear that too. Guys, thank y'all for listening. Be careful and take care.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Firedog production. Visit flightbridgeed.com for more information.